Dr. Hashim is joining.
You know who is it now?
Chairman.
You know who.
Hey, Chairman. We will give Raphael Chesori your seat.
Hello. I think I'm having a very bad connection from my end. Sorry for that. Can you hear me now?
Yes, I can hear you.
Okay. So you are saying we can
You
get
have to welcome people so that we start.
Okay. Yeah. So good evening, everyone, wherever you are. It's good to see that all of you are safe despite the current situation globally. I would like to welcome you all to today's webinar session. Actually, this is an initiative from the former chairman, Secretary Otuoma. So feel very much welcome. I would also want to appreciate our panelists for agreeing to volunteer for free and offer information to us. So I hope for all the participants, you are going to learn from the team that we have. So feel very much welcome. I don't want to take too much time because we have a lot to discuss. So over to you, moderator.
Thank you very much, Chairman. So since we have 6 presenters and all of them are already present, I would suggest we agree that we'll end this meeting, for example, at 6 or at 7. Once we agree on when we will end it, there are 3 ways the presenters can make their presentations. One way is each presenter takes 5 minutes. You say your bit, and then that is assuming it's an hour's meeting, so that the 6 presenters in total take 30 minutes. And then after the 6 presenters have finished their statements, we have questions. That's one way. Another way is each presenter takes the 5 minutes, then we have questions. And then the third way is only one presenter gave me a PowerPoint presentation. So that would have worked well if everybody had a PowerPoint, such that when a presenter is making a presentation, I post the PowerPoints, and when I post the PowerPoints, the presenter would prompt me to go to the next slide. But only one gave PowerPoint. So which method would you be most comfortable with? The one of everybody presents, then questions come after, or every after presentation, questions follow? PowerPoint is only one who has a PowerPoint. Thank you very much. I would like to listen from the panelists.
I think it's better when every presenter gives a bit of their part, and then all of them talk, and then we have questions and comments.
Another panelist.
I think to keep track, we can present and questions are asked maybe immediately.
You are fading, and it will be nice you say your name and then you state what you wish to state. So for the benefit of the others who may not know you.
Okay,
continue.
I'm Bobo Mondi. I'm of the opinion that maybe you make a presentation and people ask you when you finish, so that maybe they don't forget.
Okay, thank you very much. Another presenter?
Mine would be the former suggestion.
Your name and then you say the former.
I'm Joseph Ruput.
Okay, and then just for the former, there's a chat where you can type in a question, or you can say if you're not listening, if you're not hearing, or you can say anything. There's a chat. I'm sure you can access the chat, all of us, isn't it so?
I just think the one that all presenters say speak, and then questions to come after that.
Thank you, Robert. Another one, another panelist. I've heard from 3 panelists. So there are 6 of you.
Okay, if I may add something, I think this is
your name, and then your name, and then you add what.
This is Capis Otieno. So I think all of us can present, and then the questions later. Otherwise, both ways could be okay. Each presenter do the presentation, and then the questions, or we all present. But I think we can all present, and then the questions later.
Okay. So now there are only 2 panelists who have not commented. The one from the Nuclear Regulatory Authority and the one from Italy.
The one from Italy is the one who has said that we all present, and then the questions later.
Then the nuclear regulator.
Well, I'm not the nuclear regulator, but my name is Anthony. My take would be, so for the interest of time, we can always type the questions on the chat. We can always type the questions on the chat. Then hello? I'm saying we can always type, we can always type the questions on the chat. Then the presenter follows and just presents and responds to the questions, so that we avoid back and forth. So we can always be typing the questions on the chat section.
Okay, thank you very much. I think then we will go with every presenter makes a presentation. It's now 3 minutes to 6. So if every presenter does, like, let's say the first round, is 5 minutes too much or too long or too little?
Too little.
Who's saying it's too little?
This is I think 5 minutes would be too little. If you can add, let's say 3 or 4, maybe 8 or 9 minutes.
Oh, you know, if you had a PowerPoint presentation, it would have been extremely easy to give you more than 5 minutes, because people would follow your PowerPoint presentation. But when you are speaking from probably your own notes, and nobody else is privy to those notes, it makes people either have to write notes, and in the process, their concentration is not as good when people go beyond 5 minutes. That works especially with physics, but I don't know if you'll agree with me. Because you can have, instead of more than 5 minutes at one go, you can cut it into little bits. You can have your 10 minutes, but not at one go. You have like 5. Then later on, if there is any need of clarification because of a question, you have another time. Otherwise, if everybody was to take 8 or 10 minutes, it will imply a whole 1 hour of listening to the 6 people, because 10 minutes times 6 is 1 hour, and people's concentration span, again using physics, it rarely goes beyond 40 minutes. And that's why I would like to because only one gave a PowerPoint, I imagine you're just going to talk either from your notes, but for us who are listening, it is from your head. So to follow you, more than 1 hour of listening to 6 people or thereabouts would be strenuous to the participants who are following you. I'm done. Is there anybody who still wants more than 5 minutes?
Yes, okay. This is Capiso Tieno from Rome. Okay, I'm the one who has called for more minutes other than 5 minutes, and I have a PowerPoint. And I was asking, like, if I'm to share my PowerPoint, which is the functionality, or I could just use my PowerPoint and then you listen to what I say.
It's 18 hours.
So it is 6, eh? Is there anybody else who wants more time than the 5 minutes I'm proposing among the panelists?
Yeah, if I can suggest, this is AK. Folks that are not presenting, maybe they may want to put their microphone on mute. The background noise is, I think, is interrupting others from understanding what folks are saying. Just a suggestion.
Actually, it's an excellent suggestion, Karim. If you're not presenting and if you're not talking, it's better to put your microphone on mute. And also for people who have not so much bandwidth, you can always also put your video on similarly on mute. That is, you take out the picture, then you have more bandwidth. So going back to the panelists, any other panelist who wants more than 5 minutes? Okay. Silence in Kenya is usually meaning everybody's agreeing. So Capis from Italy, then you'll be the last presenter. When people don't really have much concentration. So if you don't mind, among the cultures we have now taken is ladies first. Dr. Pani, would you like to go first? It is 1 minute after 6.
Hello.
Yeah, hi, Koten.
Can you hear me?
Yes, I
can
hear you. Yes, I can hear you.
Okay, that's good. I was struggling with that. I don't mind whichever way. I don't have a PowerPoint, but I can go through quickly. I can use the 5 minutes that you're giving for presenters to give the input.
Oh yeah, I've just seen that Dr. Wambani left the conversation, which implies we will. So Koteng, since you've just spoken, could you please start? Because I think you and I, we are the oldest here after Dr. Wambani. You have your 5 minutes, now it's 3 minutes past 6.
Okay.
And the idea is this regulator. Now that we have the COVID-19, could you tell the participants what the regulator is doing so that the cases of COVID-19, especially among radiation workers, this is the oncologists, the radiologists, the radiographers, the medical physicists, the nurses, other doctors, and everybody else who must work in a human health environment that is a medical facility. What more than what you've been doing is the regulator doing so that we keep the cases of COVID-19 in our population down, and more so to the radiation workers? Thank you very much. Over to you, Koten.
Thank you. Thank you, Chair. As a regulator, our issue is our mandate is to license facilities. As you know, the regulator is mandated to authorize, inspect, and enforce the law. So basically, ours is safety to the radiation workers, safety to the members of the public, and to some extent the patient. And you know, we do this in radiation protection. We basically know that we look at the issue of shielding, distance, time. And as in Kenya, we know we have got diagnostic radiology, radiotherapy, and nuclear medicine to look at. So basically, safety to the workers is the main key issue here. And also, we ensure that quality control of the X-ray machines is done so that as the pictures are taken of patients with the COVID, you can get a good radiograph that a radiologist can use to find out whether to diagnose whether somebody has got COVID or not. So basically, that's the biggest part that you're playing in the matter of COVID. In regard to patient dose, we are dealing with matters of doing CTDI. We are working together with KNH on an IE project to ensure that the CT machines are giving doses within limits, or within limits that are there with other continents. Hello?
Yeah, thank you very much. We can hear you. You've taken 2 minutes. We can hear you, Arthur, but you've stopped talking.
I can talk. I can add some more information.
Please.
Previously,
have you come up with any protocols which you can share with both the radiation workers and anybody else in human health?
No, we've not done that. Our work basically is to regulate the use of ionizing radiation, and that's what we are doing. We license the users and the machines themselves. So basically, we've been dealing with issues of radiation safety when we were under Radiation Protection Board, which was to check the safety of radiation worker, members of public and the environment. And now since January this year, we've turned from being Radiation Protection Board, now we are Kenya Nuclear Regulatory Authority. And now we are dealing with matters of radiation safety, nuclear security, and safeguards. So apart from taking care of matters, radioactive materials and nuclear materials, we have also opened up to non-ionizing radiation. So we'll be regulating that as well. The people who use now to help us do more of these services are those we call technical service providers. As the IEA would like us to separate work between regulatory affairs and radiation services. So the technical service providers undertake radiation safety assessment of radiation facilities. They do quality control of X-ray machines. They undertake personnel dosimetry of workers. They take care of transport of radioactive materials in between one point to the other. As a board, we are still involved in issues of waste disposal and especially waste from use of nuclear medicine, where we observe delay and decay, dilute and dispersion from hospital waste when you're looking at effluents from patients, contaminated disposable materials, syringes, vials, etc. Where they are solid waste, these one are immobilized in 200 liter drums in concrete matrix and stored at the Central Radioactive Waste Processing Facility. And I've mentioned before, we are on a project with the KNH to check on patient doses to ensure that they are not being overexposed when diagnostic procedures are being undertaken. So apart from CT that we have done about 50 machines. We are thinking in the future we'll go into radiographic machines, mammography, horoscopy, dental, and others, so that we can have patient dose reference levels, not only for Africa but for Kenya. Right now, the ones we have done for CT, Dr. Rose Nyabanda, who is the project coordinator and the radiologist from Kenyatta, will tell you that they're trying to publish this information. And we are working with Dr. Nyabanda and Mr. Bob Omondi, also medical physicist from Kenyatta, in this particular project. I think I'll leave it at that.
Thank you, Koteng. You've exhausted your 5 minutes. Dr. Ambani had left, but now she's come back. But who would like to be the next panelist? After Koteng, because that was the nuclear regulator.
Hello.
Yes, your name?
My name is Mamati.
You're on the program.
Okay, yeah. Hello?
Yes, I know. You're on the program?
Yes, I mean.
Not as a panelist.
You know, we had a flyer with 6 people. So one of them has just presented.
Okay.
Yes, so I was asking if you are one of those 6. Because one has presented, that is the nuclear regulator. So now we have 5 more. That is the... So among those remaining 5...
Can I come in?
Who would like... Yeah, Dr. Ambani, please. You have 5 minutes and it is 11 minutes past 6. So you have 5 minutes starting from now. Continue.
Okay. Thank you again for inviting me for this talk. I'm a pediatric radiologist by training, and at the moment I have retired from public work, but I still have interest in radiation safety because I did quite a bit of research, and I am still doing some research even in retirement. And I would like to share my experience with the radiation protection, because one would wonder, why should we have radiation protection? But we know that the different types of radiation, that is ionizing radiation. First of all, we have the natural occurring radiation, and then we have man-made. And amongst the man-made, especially in our country, it's actually in medical use and also in industry. But really, those who are really affected are mainly the population. And the population in our country is affected by coming for medical treatment, those who have health problems. And then we use X-rays, which is really a modality that can really give a lot of radiation to the patients and to those who come to the hospital. We have groups that are not sick. For example, those who come for medical examinations and they have chest X-rays, they are exposed to radiation. So it is very important for us in medical practice
Dr. Ambani, you have disappeared.
I don't know. I'm getting
Just
network
continue.
is a problem
continue
on my
talking
side.
Continue. We can hear you now.
Let me just keep on talking. My phone keeps on going off and on. Network. So in particular, in medical, we use a LARA principle. That means as low as reasonably achievable. So it means that we must optimize our practices to improve image quality for better diagnosis of the disease or the health problem. And we usually involve the clinicians and medical workers who request for these examinations. And we ask them, is it really necessary for the patient to undergo the examination they have asked for, especially the high radiation modalities like computerized tomography, which is commonly known as CT scan. So in those modalities that use very high radiation, and then we have the electromagnetic radiation that is emitted by magnetic resonance imaging, and that is very dangerous for the growing tissue of children. And that's why we also limit the use of MRI, which is giving electromagnetic radiation in children. Again, of late, we are seeing effects from, again, electromagnetic radiation in terms of communication masks, especially you've heard people talk about 3G communication, 4G, 5G, and so on. Those are electromagnetic radiation. And then within our homes, we have gadgets that emit radiation. So you have gadgets like the microwaves, we have the gadgets like the TV monitors, and the electrical cooker. Many people don't know that a lot of radiation comes from electrical cookers. So for us in health, we would like to educate the mass on the effects of radiation, because we don't see them immediately. You only see them immediately if it was a high dose that was passed through you. For example, radiotherapy, where they use it to kill the diseased cells, and at the same time, it also kills normal cells. So we would like to have a better management for patients, collaborate with the clinicians, give them many talks on the hazards of radiation, because if it affects a cell right now, most people who don't get immediate effects will have those effects in future, because it will have altered the DNA and the coding. So you'll find in the generations to come is when now children will be born with the effects of the radiation that either happened in the parent, and that DNA was
one more minute, Daktari.
So the things that we like to do to have radiation safety, one is well-trained personnel. We should not encourage people who are not trained to handle radiation to do so. Two, the regulatory body plays a very important role in regulating the use of these machines, because if they don't regulate, then we'll have it in hands of people who are just interested in the commercial aspect, and will radiate our people. And in future, they'll start having the effects of radiation on the body cells. We need to look at children because their cells are growing. And in children, we have done at least, I did a study and developed some diagnostic reference levels in children. And more so, we did a lot of quality assurance, quality control of the equipment in the whole country, and gave a good article that was published. And I would like the medical fraternity in the country to renew. Again, now we have digital imaging. That digital imaging, they should now look at what are the diagnostic reference levels for this digital. Are they better than what we are we had suggested earlier on, in children especially, so that we improve optimization of practice and image quality. Thank you.
Thank you very much. Thank you very much, Daktari. 4 more participants to go. Who would like to go next?
I can go next.
Go ahead, your name, and then you continue. It's 19 minutes past 6, so you have 5 minutes.
Yes, from left and saying
We can't hear you. There's too much echo. So if you please mute your mic, and also you can remove your picture to increase the bandwidth. Thank you. You are not clear.
You can remove the visual and remain with audio only.
So who wants to go next?
Okay.
The other 4 panelists, you are quiet.
To go.
Yeah, then your name and then you continue. It's 21 past 6.
Okay, thank you so much. I'm Joseph Rugut from Christian Health Association of Kenya. I would like to add a contribution to radiation protection in health by highlighting the life or the contributions and the roles of the biomedical engineer. In health, we have so many medical devices, and yet WHO tells us that over 4 billion people still don't have access to adequate, reliable, quality, and appropriate safe diagnostic and therapeutic radiology services in the world. So as biomedical engineers, we are viewed by WHO as trained and qualified medical engineering professionals who design, evaluate, regulate, and maintain, and even manage the medical devices, including training for their safe use in healthcare around the world. So these people are usually called clinical engineers or biomedical engineers or healthcare technology managers, depending on their regional terminology. In health, we have about 3 fields where the radiology equipment are applied, and these are diagnostic areas, which is the general X-ray, dental, mammography, CT scan, and others. In therapeutic, we also have radiotherapy, others like brachytherapy, and even nuclear medicine. And then there is what the applications where it's just for image guiding during interventional procedures. So we find that the needs for safety are equipment maintenance, which helps us, which helps the equipment's assurance. For example, we have to access, manage, and ensure that the technology is appropriate, and also the premises are also appropriate with the correct climatic conditions. Secondly, is to ensure that the facilities comply with the required standards, accreditation requirements, and also compliance with regulatory authorities who have the standards or the limits for patient doses or radiation that is supposed to emanate from the equipment. Thirdly, is to design and install shielding, which prevent unnecessary radiation to unnecessary public or the staff when they are doing procedures. And fourth is to do routine and planned maintenance, which includes quality assurance and quality control, calibration and validation, so that we know that the equipment are producing exactly what they are set to produce. And then safety mechanisms, ensuring that they are working during the inspection and also during the prevention and other maintenance visits, inspection visits, so that there are no accidental exposures, there are no mechanical accidents or electrical faults. And we also have as another activity is to do daily appraisals of operators so that their skills and proficiency is appraised, whether they are working as per using the equipment as required or they are mishandling, and also upgrading the skills of the maintenance personnel in a facility. And then later on to recommend the end of life of our equipment, because an equipment has to reach an end of life and there has to be an appropriate way of decommissioning it. So most of the challenges in equipment that give a risk of non-protection or risk of exposure and required exposure are the extent to which users understand the operational mechanism of equipment. The technology advances so fast and the digitization also goes up so fast that you cannot, the users have to be made to catch up, to cope with those technological changes. And the equipment also varies so much in models or types, so that when you want to get certain spares or support, you have to roam around the world to get connections. And the challenges again that again are giving us in our risk analysis, we find that also the biomedical engineers require some competency-based trainings. Trainings that are available usually are more academic, like climbing the academic ladder. So when you climb the academic ladder, you just go from a diploma to degree to master's. But sometimes you need a horizontal kind of skills enhancement to specialize in an equipment or in a technology. And then errors that users or new users do or perform in equipment have caused many serious accidents. And then if we are to avoid all this in equipment, is to stick to appropriate selection and technology, which fits a certain climatic area. Also, we need to encourage people to budget for preventive maintenance, not just wait for breakdowns. And then we also can prevent this by sticking to licensing and operating regulations by the regulator. And then, of course, open doors for practical trainings and competency-based skills enhancement for our engineers and technicians. And we do that a lot with our Association of Biomedical Engineers, we call AMEC. Thank you very much.
So you are finished?
Yes.
Thank you very much, Engineer Rugut. So we have 3 more presenters to go. Who would like to be the next one? if everybody is quiet, then we can listen to Capis from Italy. He had a PowerPoint slide of 23 slides. Capis, you are still there?
Yes.
Yeah, please take over, because the other two presenters have gone quiet, so you can take their time. Because you had requested for more than 5 minutes. Please go ahead.
Okay, thank you so much. I don't know whether you're able to see my...
Yeah, we are able to see. We are able to see. Anybody who doesn't see the PowerPoint presentation?
Okay, thanks again.
It's 29 past.
Okay, thank you so much once again. So my host is Regina Elena, National Cancer Institute. So I'll take you through very fast. We'll talk about the medical use of ionizing radiation. I'm also going to look at LCRP, radiation exposure reports with regard to the United States, and also some recent medical overexposure events. And then we look at some guidelines by the basic safety standards. Then very fast, we look at the summary. So one thing that we all understand is that the use of ionizing radiation in medicine are basically in two areas, and that is in imaging procedures and also in the treatment procedures. And usually for us to ensure accuracy and safety aspects, as other presenters have said, you're supposed to have device performance, quality assurance being done, safety checks has to be done, things to do with the calibration, identification of the patient. So we are supposed to have, in general, daily, weekly quality control. And this one will ensure that at any point we have the correct patient, anatomic site, and of course, correct dose. Now, one unfortunate thing is that we normally don't have any particular regulation that can limit how much medical radiation should go to a particular patient. Usually the practitioners are based on practice guidelines and recommendations, and also borrowing from the international best practices due to the fact that any ionizing radiation being given to the patient should have some associated benefit. So we do have three classes of individuals, that is the patient, staff, and members of the public that we consider under safety and protection. So briefly, the NCRP report 93, the annual effective dose equivalent to the US population, that is in early 80s. So we get that the exposures majorly were coming from the natural sources, accounting for 82%, and man-made 18%. Now, of importance here is the medical use, which was by then was accounting for 0.53 millisieverts, that is per capita. So if you look at more or less current, that is 2006, this number has increased to almost 6 times. Today we are 2020, and of course, you could imagine maybe the number, the medical use has really increased. So very fast, I'll talk about some recorded radiation exposure events. It is events in quote, also to mean some accidents. Now, some of these have been recorded in the mainstream media and also in research journals. So I'll just, for clearance of the stories, we'll borrow some information from the New York Times. So the story begins with a 23-month-old boy who was supposed to take some brain scan using a CT. So the operator at the machine somehow pressed the button, as it was said during the testimony, that the operator just pressed a few times, but what resulted was 151 scans. Now, this translated to 11 gray. It was estimated that the boy had 39% chance increase of cancer. So one thing that we learned, that the operator forgot that imaging devices also give those. I think it was a very fatal error. So another imaging incident took place in Los Angeles in 2009, where we had an operator administered up to 8 times the normal radiation dose to some 200 patients who had a stroke. Now, this one continued for a period of over 18 months. But the operator was doing this in the sense that you want to get clearer images of the brain. And you can see the results of what he did. You can be sure that some of these victims could never get their hairs back. So in the therapy, I just want to mention a few. There are so many that have been recorded, but this story begins with the first linear accelerator called Therac 25, which was manufactured in Canada. So in the mid-80s, this was the first linear accelerator, but it had a lot of problems, especially its software. So the worst problem with this machine was that the software that was running the computer was more or less very basic, and you could find that the therapies could outrun and they change the software. So it happened in most cases that the operator at one time reprogrammed an electron treatment at a photon current. Now this resulted in 250 gray in 2 seconds. In fact, those people who have been working in nuclear medicine or in radiotherapy knows that at any one moment, we cannot have even over 100 gray for any particular treatment. But this one was able to deliver 250 gray in 2 seconds. So a lot of people were injured, so many died from the localized overdoses. So this was the Therac. Actually, many people say that this was a linear accelerator which had the whole human being as its target and not the tumor that is supposed to be treating. So another quite recent 2010 was a kind of a new technology called stereotactic radiosurgery, which was being done by Brain Lab. So the problem here is that a Brain Lab or for this tech is delivering a very small field. So for somebody like a medical physicist to do the calibration is supposed to use a very small chamber. But in this case, a medical physicist did use the same chamber that is being used to do the calibration of larger fields. And as a result, over 76 patients were over-edited. Now, the same thing also happened in another state, Florida. 77 patients were also over-irradiated. So if you're able to see the 2 circles, the bigger circle is representing a larger field. The smaller circle is representing a small field, the dotted one. And then what you see horizontal is the chamber. So if you have a larger field, which is the bigger circle, then that chamber, you can use it for calibration. But in a case where the chamber is bigger than the field, then it means that if you do calibration, whatever you end up getting will be a wrong calibration. Now, unfortunately, if you look at the dates, this is February 2010, the same incident with the Brain Lab had also taken place. There's a mistake that had taken place also in Toulouse, France, that is 2007. Also, a medical physicist had done a wrong calibration. So this is something that maybe if the information could have been shared, maybe we could have not had the same incident taking place in the this state that I think Missouri and Florida. So another technology here is IMRT, which is intensity modulated radiation therapy. So those in the radiotherapy department must have known that we have the 3D CRT, we have IMRT, we have VUMAT, we have SRS, we have other techniques. So this one is more or less complicated, usually have high dose rates. So we have this guy called Jerome Parks. He had head and neck cancer. If you can see the figure on the right, but something funny did take place. His plan was made well initially, and for the first 2 or 4 exposures or fractions was done without any issue. But then the oncologist decided that the plan should be done again, and it was done. But in the process of saving the plan so that the patient could go on with the treatment, Then in the process of saving the plan, something awfully went wrong. Some part of the plan were not saved all. And the most important part here was the MLC. MLC is multi-leaf collimator. Those leaves that are supposed to be controlling the dose that are going to the tumor. So in the subsequent treatment, we find that this guy was treated with wide open field. If you can see the diagram on the right, this is what was supposed to be there. You can see the MLC are there. Those are the MLC. But what actually did take place after the replanning was this. The whole of this place received radiation. And as a result, the non-target volumes received 39 gray. And all it was done, and the plan was checked, it was found that IMRTQA, that is quality assurance, was actually not done. And you can understand this because remember, this is somebody who was already undergoing treatment, and therefore, if the plan was redone, there was not enough time, and therefore they hurriedly did. And these are some of the mistakes that normally do take place. So this is drawn before he was diagnosed with this vibe, and then later he died after 2 months due to overexposure. So summary about reported radiation exposures accidents between 1980 and 2013. So if you can see from the first graph, reported overexposure accidents in the early 80s were quite high, 173. But somehow the number also increased between 1990 and 99 to 37. But then generally we have seen a decrease in the reported exposures, and to the current state, that is 2010 to 2013, we have 66. Also, the number of overexposures, the number of people have also reduced from 1,014 to 85 up to 2013. So what could be the causes and the classes of errors? Some of the classes of errors, we can say that usually you can have a target being missed during treatment, either in part or the whole of it. Sometimes a wrong prescription, that means wrong dose. A wrong patient might be treated the way it sounds, it is possible. Some people have been treated by other people's plans. The causes of error could be maybe the quality assurance is not done correctly, data entry and calculation, flawed treatment plan, hardware malfunction, software data, for example, the one which took place with the therapy 5. So what could be the impact of errors? I want to identify 3 individuals here. One, the physician, the therapist, and also the medical physicist. For the physician, which is the oncologist, in case he had some errors, the individual patient can be affected, or the class of patients can be affected. The same applies to the therapist. But for the medical physicist, in case he does something wrong, for example, linear calibration, then this might affect all the patients. So the medical physicist actually has to do the right thing all the time. So the basic safety standards tells us that patient protection is ensured when the physical and the technical aspects of radiation medicine are under the supervision of medical physicists, which is very important. So in summary, what are you supposed to do? The people involved, we are supposed to be always aware of what we are doing. Remember, and radiation cannot be undone. We should think through and cover everything that we think might go wrong. We should have a thorough understanding of equipment and the data that is used for patient treatment. So we are supposed to define our responsibilities and ensure that at all times the members of the staff are educated according to their tasks and they are kept up to date in their training. So that marks the end of my presentation. Thank you.
Thank you very much, Capis from Italy, for the presentation. So participants, we have quite a number of questions which have come, and if we cannot agree, we can go to the Q&A session. And for the interest of time, because most of the questions have been put on the chat, I would like I would like to know if the regulator is still in the house. That is Koteng.
Amin.
Yeah, actually many questions are for you. So if I'll just pick two, and then so that I can also ask the other. We can also ask the other presenters. So this is a question to Mr. Koteng. So in this time of the pandemic, how has the operations of Kenya Nuclear Regulatory Authority evolved? How are you conducting your work? So like on Monday when you woke up to today, Friday, when you left work, can you tell us what is happening at the Kenya Nuclear Regulatory Authority and how you are conducting your work? Koteng, please.
As you know, we are a regulatory body, and our work includes, as I mentioned earlier, we do authorization, we do inspection, and law enforcement. So what we do basically is to license. Like you had that when you are doing your work, like in radiotherapy, you need to have qualified personnel, even in diagnostic radiology. We ensure that people who are licensed to use those machines are properly qualified. Then even the machines that are used have been done acceptance testing and have been done quality control, and they are working optimally. So that's the much you can do. Other bit and the work in the hands of other health workers. For example, radiographers handle the X-ray machines, radiotherapists handle the therapy machines. So we don't go into there. So from Monday up to today, this week I've been on off, but what I do Monday to Friday is we plan. We have got an inspection planner for the whole year where we go and inspect radiation facilities all over the country, and we license them. That's basically what we do. If there's a facility with a problem, we are given the powers. We can stop the use of that facility or the machine until it is properly taken care of.
Thank you very much, Koteng. The last question to you is, can you share with us an example of the guideline or technique in place that the Nuclear Regulatory Authority has implemented to ensure workers' protection?
Workers' protection.
Can you share with us?
Workers' protection, basically radiation protection. You know, we have the issue of shielding, the issue of distance and time. So in medicine, most of the times, if you look at diagnostic radiology and radiotherapy, we look at the issue of shielding, because the operator should not be inside the room. It's only the patient who should be there, and the operator can operate from outside the room in radiographic procedures. Fluoroscopy at times requires that the operator is inside the room next to the patient, but to ensure that they also have lead gowns that is supposed to protect them. On top of that, these are people working in diagnostic and therapy and nuclear medicine. They are required to be monitored for radiation dose. So we ensure that before they are licensed, we ensure that the place has been checked for safety, the machines are in good working condition, and the workers have got personal radiation monitors.
Thank you very much, Koteng. I would like to know if Dr. Ambani Sindika is still present, because there are questions for you.
I'm still present. I'm listening.
Well, thank you very much, Daktari. So I'll ask you again 2 questions. This is from the participants. So one question, can you tell us anything about the dose reference levels, specifically in Kenya and in East Africa, dose reference levels?
Okay. Just before I go to those reference levels, I'd like to add something about protection. And protection of radiation in the hospital is not only to the workers, it's also to the public. And quite often, the public usually just get unnecessary exposure because they go into areas that are sort of secured and told, they are told don't come to this area, but they still go to those areas. So I think when we are talking about radiation protection, we should also remember the public, the people who come, the patient and the patient carers and so on, and the hospital staff that does not work in the radiation area. They should observe the restricted areas and stay away from them. Now, when it comes to those reference levels, this is just an indication of sort of protocols and the type of radiation factors that you have put in place for an optimal image or high quality image for diagnostic purposes. And that image should be used to influence patient management. So diagnostic reference levels it's not something that is static. It's very dynamic. And it is a sort of something that it's a level of doses that you use for a near optimal picture. And it means that you must position your patient very well. You must understand what the doctor is looking for. And once you understand what the doctor is looking for, you must know what particular views am I going to take. And those views that you take, then you must record that data. Record that patient data down, all the demographic data, how much radiation, your exposure factors, and how much radiation that has gone through. Because these days, the machines also indicate the amount of radiation that has gone through the patient. Then you use that diagnostic reference levels to see whether you are within those factors. I don't know if I'm clear or.
Yeah, we can hear, and you could summarize the answer because there's another question for you.
Okay, the answer, the summary is that for us to achieve diagnostic reference levels in imaging, it's good to document every procedure that you do. Keep that data properly so that you can always develop diagnostic reference levels for those who are new in the and those who are learning from our learning institutions, that they should know as when they go out, they will know that I must work within this limit. But the limit is not really specific to every patient. You have to look at other factors like patient weight, patient height, or just the thickness of the body from anterior to posterior and so on. So if we make recording of all those factors, then we can be able to develop diagnostic reference levels in every imaging that we do. For example, we can have diagnostic reference levels for fluoroscopy. We can have diagnostic reference levels for CT scan, for ordinary pictures, X-rays, because those are the ones that we do quite a lot in our setup.
Thank you, Daktari. So the last question to you, Daktari Sindika, is: yes. Are there long-term studies showing the negative effects of radiation emissions from daily use gadgets like phones, laptops, etc.? Are there long-term studies?
They are not as much, There aren't very many, but this is what I'm saying, that if we were interested in actually seeing the effects on health, and then you took a very good detailed history and you document that, then that data, if as a country we can collect it and we say, okay, this person has been working in a high radiation area, for example, those who operate telecom equipment, they have a room where they go and they look at things, and all those things are actually emitting, the control rooms, they are emitting radiation. If somebody can collect that data and see when this person gets sick, for example, has cancer, or their grandchild has cancer, the effects could have been from the time, the actually grandfather, because he has passed a gene on that has mutated and becomes something else. And that's why people say that this runs in a family. It's because the cell was affected and the DNA gene was sort of affected with the radiation and split into something else that now goes through the family. So we really need to document our... Hello?
Thank you, Daktari. You've come out very clear. Is the engineer Rugut still present?
Yes, I'm present. Can you hear me?
Again, I'll have two questions for you again from the participants. Yes. So the first question to you, Engineer Rugut.
Yes.
Do we have preventive and predictive maintenance program? And you can explain what is preventive and predictive maintenance program to the participants. Thank you.
Thank you very much for that question. Yeah, we have mainly about 3 types of maintenance. One is usually the corrective or the repairs that are usually emergency type of repairs because of a breakdown. Then there is planned preventive, which goes with inspections, so that you can do some major adjustments or proper lubrication, tightening of cables. So that is the planned preventive. Then predictive usually is very important because it enables you to, through data, to know what an equipment may need and at what frequency. If equipment you have to replace, for example, in motor vehicles, we know very well that tires can only go for such mileage and they will change. So for equipment like the CT scanners, even the manufacturers themselves, they advise certain hours for the tube to run, then you can change it. Because maybe after that time, you can no longer calibrate, you can no longer control for the output, no matter what you do. So predictive is important so that you have enough spares and replacements in stock. Again, about the radio frequency equipment, that I felt like saying that those people who are involved in radio frequency equipment, there are appropriate regulations and PPE, protective equipment for them. So at times the people in telecommunications and using radio frequency equipment, they need to adhere to protective equipment because those electromagnetic waves are usually harmful. Yes, thank you.
Thank you very much, engineer. There's a question which is for everybody. So you since you are on the floor, you can be the first one to try it, and then I will invite the other panelists again to weigh in on this question. This question, which is for everybody, the way it is going is it's from Vienna. How are we contributing to the government's effort of dealing with COVID-19? Or how can we contribute to the government's effort to stop/combat the spread of COVID-19. So engineer, you can start, and I will call back the others to also weigh in on that question. How are we contributing to the government's effort? Thank you.
Okay. Thank you so much, Dr. for that privilege. Surely the detection and the determining of the infection also can be enhanced using the radiology equipment. Just apart from being the government and private sector, we have been involved several times in equipping X-ray machines, even mobile ones, so that it could detect respiratory issues, problems, so that they can also help with the people who are screening to know that a patient has respiratory complications. So already with the equipment which are for diagnostic imaging, we are already doing some effort to assist the medics in their quest to determine whether the infection is there or not in a particular maybe case.
Well, in diagnostic departments.
Dr. Mbani,
yes.
Before you go in, let Engineer Ugut finish, please.
Oh, he hadn't finished. Oh, sorry, I thought he had finished.
I just finished, Dr.
If you are finished, then let's now go to Capis, because you are going systematically. That's a question for everybody, and everybody will have a chance to answer it. So again, my two questions to Capis from Italy. The first question, do we have any data that shows the number of cases that involve the IMRT therapy technique versus other techniques such as SBRT, that is radioactive seed implant? What are the success rates and for what type of cancers? Can you give us some more information, please? Do you have any data that shows the number of cases?
Okay, thank you so much for the question. So what we know is that IMRT, that is intense stimulated radiation therapy, is one of the specialized kind of treatment using linear accelerators. So usually most of the systems, especially the developing countries, use the conventional 3D because it doesn't require a lot of other peripheral devices. But 3D CRT is not entirely enough. There are some certain types of cancers that IMRT, SRS, SBRT would be more suitable. For example, prostate cancer. One thing that we know about prostate is that during the treatment, it moves. And the movement usually is caused by maybe neighboring organs like that. We also have the bladder because the bladder keep on filling all the time. So you can find that during the treatment, maybe which takes about 10 minutes or 20 minutes, the bladder, the prostate could have moved by a few millimeters. And maybe during the treatment, you might find that you are not hitting the target. So by the use of MRT, it has there's a strong scientific suggestion. You can actually modulate the plan so that you hit the target, you move with the plan. For example, you can implant some fiducial markers so that during the treatment, you can track it. And this one is only possible by using the IMRT. At the same time, we also have other cancers. Let's say, for example, somebody with a tumor in the head. Using 3D CRT may not be appropriate for certain cancers. That is why we have these other techniques like stereotactic radiation surgery. We have the gamma knife, we have the gamma camera, because there are certain cancers you may want to treat very fast with a high radiation, and then you don't also want to spend a lot of time because maybe the patient is not in a good, maybe the health is not good, may not be able to stay for a very long time for the coach. So you find that you might want to use these other techniques other than the 3D CRT. So there's a very strong indication that we should be providing this other kind of specialized, and that one has been suggested and with a lot of research, and I think it is important to understand it that way.
Thank you very much, Kapis. And can you weigh in on that general question for everybody? This is the question which was asking, how are we contributing to the government's effort of dealing with COVID-19? Or how can we?
Okay, thank you. I think to approach this question is because we know that still the medical workers or healthcare providers are still doing their work. One unfortunate thing is that even some of the patients that we are dealing with, possibly they could be infected. And maybe this is something that we do. One of the webinars, they said that as much as COVID is there, other diseases do not stop. And therefore, we cannot stop maybe giving the treatment because everybody is hiding away from Corona. So what are some of the things that the people have been doing? So just wrap it up, what people do, or the radiology department, or what they do is they have restructured their plan so that they just have one particular, let's say, radiographer or radiotherapist who is handling a certain group of patients, and then you have another one who is basically at a particular part of the system, so that they don't operate the same way they have been operating initially, just to ensure that they separate the way they work. And all the time, let's say, for example, because they use the same coach where the patient come and they sanitize, they ensure that they have the appropriate PPE for themselves. And then, of course, the usual government directions, which is being followed by everybody. So basically, it's to ensure that there is no contamination from one patient by doing the sanitization, and also ensuring that they separate the patients, and then, of course, the workers, they also ensure that they protect them.
Thank you very much. So could we have rejoinders from Dr. Ambani and also from Arthur Koteng of Nuclear Regulatory Authority on this same question? How are we contributing to the government's effort of dealing with COVID-19? Or how can we contribute to the government effort to combat the spread of COVID-19? Dr. Ambani, you may take it first because you had already started talking when Engineer Gut was present, and then Koteng will give the last word. Thank you very much.
Okay, thank you again. I think the Ministry of Health actually set up a committee, a health committee for prevention in all areas. So I know, for example, like Kenyatta National Hospital, which is the apex hospital in our country, in the radiology department, they have set aside rooms, just rooms that will be used for suspected cases. And anybody who is working in those rooms has been given protective gear, as they have not started receiving active cases, but the quarantine area, they have also put in place the basic needs: hand washing, sanitizing, cleaning of the services, and specific rooms for doing x-rays, and a specific CT scan for doing any CT scan examination. You know very well that in our country, MRI would be the best examination to look at the chests of these people, and ultrasound. And you know, ultrasound means that the operator should be so close to the patient, and certain machines are the ones that can be used. So again, in that case, they have specific, very well-trained radiologists, and they have given them protective gear, and because the contact of ultrasound, you can't scan your ultrasound a meter away. You have to be so close to the patient. So they have been given protective gear that will allow them less, contact with the patient as they do the examination, especially ultrasound. So far, we have not had any big, influx of patients with COVID. So, but still, they have designated areas, designated rooms just to take care of any suspected cases, and so away from other areas where you have patients waiting. And where patients are waiting, they have put the distance for how many patients should actually be there. So you'll find most of the ground outside the hospital is used other than inside the departments. Those are some of the measures that they have put in place to help combat the spread of COVID if we tend to get many more. But at the moment, they have contained them. Thank you.
Thank you very much, Daktari. So, Koteng from Nuclear Regulatory Authority, you could have the last word, and then we end this webinar. Thank you very much.
Okay, I think from our side, we would like to emphasize or point out or make sure that the machine is operating, the X-ray machine is operating properly. Quality control has been done so that when a picture is taken, we don't get erroneous radiographs because the quality of the machine or quality of the picture was not good enough. One way would be if the quality is not good, means you have to repeat the examination. So you are giving extra dose to the patient where they shouldn't be. And the other one also, maybe the radiologist now looking at the picture cannot make head or tail or cannot make a proper diagnosis. So when a machine is properly taken care of, the biomedical engineers have done their maintenance bit, and the physicist has done the quality control, and the machine is operating properly, then we get very clear and good radiographs that can be useful in detection of the COVID-19.
Sorry, there's a question that has been directed to me. If you could allow me just in less than a minute to answer. So,
that's Capis from Italy.
Yes.
Yes. Is that question about that? Clearly, there is need to ensure that accidents related to clinical radiation exposure are minimized. From your experience in Italy and elsewhere, what would you recommend for Kenya?
Yes, thank you. Exactly, that is the question. Yes, exactly.
Okay, then go ahead and take it.
Okay, thank you so much. The person who has asked the question. So the answer would be very simple from my side, that for us to ensure that we don't have such kind of many accidents taking place either in diagnostics or in therapy, because one thing we learn is that once an irradiation has occurred, you cannot undo it. So one important thing that we cannot run away from is that we are supposed to have proper training for the personnel who are going to handle these machines. So things like certification, for example, once somebody has gone through the schooling, there should be some form of certification, and also to ensure that there's a continuous training on the new techniques, because every now and then we are tending to improve our ways of doing things. And then for any organization, they should develop what you call the protocols that should guide them on every procedure or a technique. And then, of course, we can also not run away from teamwork and proper communication among the staff. I think it will be very, very helpful. So even here in Italy, that is mostly what I see. People actually work in such kind of areas are properly trained. And you'll find that there is a very high level of specialization. You don't have one person who knows it all. You'll find a medical physicist, there's a particular thing that is doing. Another one is also doing a particular thing. So I think proper education generally is what is going to help us even reduce the chances of having these accidents. Thank you.
Thank you very much. We are 1 minute shy from 2 hours. So since we had planned this to take 1 hour 45 minutes, and now we are going to 2 hours, please, I would like to invite the chairman. This is Wilson Kairu, to take the last minute, and then we can end this webinar. Thank you very much, everybody. I really appreciate all the panelists and all the participants. So, Chairman Wilson Kairu. The chairman's minute has gone by. It is like it was a call for silence. I think I would like to inform all of us that this is just one of the many webinars which will come, whether we have the COVID-19 or COVID-19 ends. And I would like anybody who in future would want to participate in the webinar to be looking out on the EARP executive when they give notices. So I would like to stop recording because we've just finished 2 hours. And then if there's any other thing, I'm available, and anybody else can still be available. But this webinar is over, and anything after now, it is a side chat. It is not going to be recorded. Thank you very much, everybody.
Okay, thank you so much. This is Capis for providing this platform. I think we have shared a lot. I've learned a lot. I've learned so many things happening in Kenya. I wish you guys will remain healthy. We pray for us here as well in Italy.
Thank you very much for inviting me to this webinar. I'm very grateful to have been part of it. And I just urge that all radiation workers should keep proper data and documentation of their patients so that we can develop diagnostic reference levels, or we can develop protocols and not just use protocols that are given to us. Thank you very much.
Okay. Thank you.
Thank you very much.
I'm very grateful.
Sorry, I think I lost connection at some point. I would really want to appreciate all of you for being here today